Hello and welcome to today's episode of Future of Care. I'm your host, Dr. Arnab from Home Care Association of India. And today we have a very important guest, Dr. Sunil Chandy, a renowned cardiologist and a former director at CMC Vellore and currently leading the healthcare initiatives at ITC India. Dr. Chandy, I'm really feel honored and privileged to have you with us today. Thank you for joining.
Thank you. Thank you. Thank you. My privilege as well to engage with you on this emerging topic of importance, home care, and other things that will be on this podcast. Thank you.
Dr. Chandy, let's start where your story shines the brightest, CMC Vellore. What is CMC doing differently? And not just in treatment, but how do they make people safe, and where's the goodwill coming from? Why it's so popular? What's the USP?
Okay. All right. That's a very deep question. I know we have time limitations, but let me start by saying historical facts. CMC is one of the oldest private institutions, medical institutions in India. It is 125 years old. It started in 1900. So, it has become a time-tested brand of healthcare, which has spanned over this. It's a very well-oiled, time-tested product. So that contributes to this huge amount of trust that patients have in terms of receiving healthcare. Second is CMC's pioneering initiatives in specialties in the 1940s and 50s, having started neurosurgery, cardiac surgery, cardiology, many things that at that time in India was a first mover advantage that CMC got. And it was pioneered, established, difficult days, but it had a head start, and many people who had these specialty related illnesses, especially from the northeastern coastline, would come to CMC because there were other hospitals, but it was in a very, nascent stage of development. The third is that it has earned the reputation by virtue of its faith-driven ethic. It has gained the reputation of being reliable, trustworthy, ethical, compassionate, and cost-effective. So it makes a difference to patients, especially for those who we actually cater to, the middle class, the lower middle class, to come here and feel that without prejudice, they will be treated. There is a selective attention to the distance, the disadvantaged, the downtrodden. That's always been the culture of CMC. Of course, it has a very well-developed private care as well, which is not cheap, but it kind of cross-subsidizes the larger cohort of people who, even now, of course, the affordability has improved over the years. So therefore, there is this trust that has been built up over the years that if we go to CMC, we'll be attended to in a reliable manner, cost-effective manner. And that's really the crux of healthcare, So that I think there are many other small things. There's a pilgrimage value. People who come, they experience a different kind of healing, even without curing. Not everybody who comes to CMC is cured. But the whole ambience of care, of a God-centered ethos that they can feel, smell, palpate, contributes, I believe, to a large extent to that trust factor.
Yeah, there's more. Yeah, I believe there's more to it, and that contributes the overall holistic healing, I suppose.
Yeah.
So, Dr. Chandy, you have led in medicine, academia, and in corporate health. Just curious to know, what is your leadership style? Is it, you call it, because of Christian ethos, is it servant leadership, or is it something unique, Dr. Chandy?
Okay, you're asking about my leadership style,
Yes,
or what
yes.
is
Your leadership style.
So, I would say very humbly that not born leader. It is something that you gained over the years through initial experiences, through novice experiences, starting off as a clinician, okay, and from there going on up your career ladder, seeing a large number of patients by virtue of being in cardiology. Cardiology is a common problem for nearly 2.5 decades, seeing that in different levels. Somehow it conditions your mind to understand what is important. We may not be able to cure everybody, but definitely every patient is an opportunity to build a relationship, not just during their hospital visit, but even beyond. So that's actually part of leadership, to be people oriented. And that has somehow influenced me when I stepped into administration, to be people oriented. That's really the essence of leadership, not just in healthcare, but in other domains as well, even in business, is to be people oriented. It is to be, what do you mean by people oriented? It means that you as a leader, as a top person at the apex of your organization, is available, is accessible, and your whole approach to problems, to people, to issues, to challenges would actually endear you to the people who interact with you. Let's say a vendor who comes to just do hard business. A leader would treat him, as a person. Yes, he's come for business, but the way you would interact with him somehow makes him feel that there's a purpose to behind what you do, and may be willing to, give a little reduction of, hard business terms, so on and so forth. Number two is to, as a leader, especially people from the managerial level who ascend, somehow cannot shake off their micromanaging role, which is required for managers. But as a leader, you need to ascend to the first floor in terms of your approach, see the bigger picture, not get lost in the micro details, because that phase of life is over. So when you see it from the top, you see the whole organization, you see the entire ecosystem, the neighborhood, and then try and fit your leadership role into that kind of a big picture. It's like a pilot who's able to see the ground and knows where to land and how to, take his aircraft in the best way possible. The third is to trust your inner circle. Today we are living in a world where we are taught not to trust, and therefore we have processes, rules, regulations, checks and balances. But that's really not the role of a leader. That's the role of the manager. He will do it for you. So your inner circle, your outer circle, the people who you govern, you must understand that your leadership is an opportunity to empower them. As they say, it's not about having power over your people, but it's giving power to people. And in my experience, it works like magic. You take a manager or an assistant and say that this is what I want to do, this is my vision. You do it your way. I won't breathe down, peep over you, over your shoulder. So he gets empowered that, the leader trusts me and therefore I must do my best. Is it 100%? No. But I would say it's 90% that people then rise up to that trust challenge and then perform well. Most importantly, is to be lighthearted. A leader must be able to interact, communicate in a way that is not frightening. So, in whether it's board meetings or your conferences or whatever it is, to be lighthearted, apply the principle of fun and fellowship in the in as the ingredients of your leadership style. And I've tried to do that as best as possible, and it's worked for me. So you break this iron curtain that you are not approachable. It's very frightening to go into the director's room or the CEO. There's no need to do that, because in doing so, the term that you used, that you are a servant leader, doesn't mean you are servile or taken for granted. But there's a spirit of service that you are available. Because see, as a leader, people come to me to solve problems. They are coming with a problem, And my default answer should be yes, I hear you, I understand you, and I will try and solve your problems. That's all there is to it. But if you say, no, no, rules say this, I can't, I'm sorry, go to, then you're being a manager, not a leader. That's my learning of my few years in leadership, especially in CMC. And I find this is true of other businesses as well.
That's very insightful. Interesting to know your style. So, Dr. Chandy, you've seen care move from hospital beds to homes, and it's no longer limited to buildings, right? Confined to buildings. You have seen care moving from it's flowing into living rooms, communities. So, how do you
Mhm.
envision the future? I mean, home care. Where do you see it as one of the critical delivery arms of healthcare, or how do you say it?
Right. No, very insightful and very relevant question in today's healthcare scenario. Let me just rewind all our lives a bit. I'm sure it's the case for you as well. When I was a child, the most common ailments that we had as children,
Hmm.
the care was actually domiciliary. It was at home. There was a friendly family doctor, pot-bellied old gentleman, army retired, who had a plastic steth, and he would take care of almost everything that you had, whether it was cough, cold, pneumonia, diarrhea. And he had that same mixture that he would give you. Somehow it worked. Hospital visit at that time was very rare. It was only for urgent emergency problems that he would refer you because hospitals were not so many. It was difficult, public hospitals. Okay, now that has changed over the years, and thankfully so. With the increasing sophistication and new approaches to therapy that we are privileged to enjoy, better injections, intensive care, better drugs for things like heart attacks and all that, it actually has shifted that old home care to the hospital. Today, the question that you're asking is relevant, I said, because today it's coming one full circle because of a different reason. It's come one full circle because the home care is being in a way rediscovered and reformatted as an alternative to a section of healthcare which is today by default hospital care, chronic care, those that can just be at home, take care, and come once in a while. And the reason for this reformatting is need based. It is to suit the current way in the way in which healthcare is being seen. In today's context, it's become a very important development because one, the cost of hospital care has gone through the roof. It's prohibitive. 70 to 75% of people in our country just cannot afford long-term care. Even a 10-day care in an ICU becomes beyond their life earnings. Number two, there is a problem about access. The better the hospital is, the more the crowd is. Waiting lists are long. If you go there without a waiting list, you will have to wait in queues. So there are access difficulties, especially in the urban settlements. The third is that today we are blessed with amazing technology that allows a home based monitoring, home based devices, which you need not run to the hospital for a blood sugar check or a cholesterol check. Now, that is thanks to technology. Telemedicine, which came as a scaffold, as a bridge alternative during the COVID time, has become now an alternative to home care. You can sit at home and talk to your physician or a physiotherapist, and a lot of things can be done without moving out of home and doing well. It's not that it is substandard. The fourth is there is a modern domiciliary care system that's evolving. It's not just a sporadic thing, but there are organizations like Practo and others that are putting together the loose ends to make it into a standardized domiciliary care system. Okay, as a part of a satellite service of a bigger hospital or standalone services, whatever it might be. So this is the reality that home care is actually a rediscovery of the old frugal form of
Hmm.
the old Doctor Saheb who would come with a bag. Today
Right.
it's become more organized and systematized. So that's what I would think.
And you have served in Bihar. I was going through your professional journey, and there was,
Yeah,
I'm from Jharkhand, so I have seen lot many house calls. Doctor making house
yeah,
calls. So yeah, it's coming back in big way.
yeah.
And so India will soon be having a lot of mid-level clinicians. Probably
Mm,
joining,
mm,
working in homes. So how do you, if you were to design this workforce, how are you to
mm,
design it and maybe standardize so that the training that a patient, uh,
mm,
the service that he gets in Varanasi, he gets the same
mm,
kind of a service in Vellore. How do we
mm.
plan that?
Okay, so I have a viewpoint which many may not agree with. India being such a country with such variations, the
Mm,
variability, ethnic, cultural, social structure, whatever it might be. A patient with the same illness from Jharkhand
mhm.
is not the same from Tamil Nadu. There are cultural differences,
Right.
affordability differences. So, while standardization is a good thing to do, we should not attempt to standardize everything because it is
Okay.
very contextual and it is very region based. Each geography has its own style of medical care. So we need to adapt to that. Yes, there's a platform that has got standards of care as to what, but the actual delivery must be flavored, in the context of that culture. That's number one. Number two is that we have to somehow revive the Doctor Saheb system. Today, in many small cities, private clinics are closing down, standalone practitioners are finding it difficult to survive. But as far as the public is concerned, the maximum trust that you will have as a resident of a village is for your good old doctor.
Right.
He may not be the best, but that trust factor, which is the crux of beginning healthcare. So instead of replacing them with a modern system, which is a satellite service of a big brand in the metro or in the nearby city, you should embrace the doctor, private family doctor, into the system so that you don't disrupt that trust factor. Okay. In a
Mm.
village of, let's say, 500 families, there's one person that everybody trusts. So instead of saying you move out, you are not MBBS, you are not good enough, I will bring up person and we'll connect with telemedicine. Yes, on paper it works well, but we have to be inclusive of them. So what it will do in the short term, you've not disturbed the trust factor. In the long term, there'll be many, many doctors who have retired from government service, public service, who are
Mm.
native to that village, who will see that, yeah, I can do good service. Let me come back to my, and there's no better doctor than your own native doctor, because he understands many things, the nuanced nature of healthcare for your village. For Raxol, I worked in Raxol, I worked in Saharanpur. It's different. So we should not attempt to over standardize. Standardize it at the top level in terms of policy, but in terms of ground operations, allow the local culture to speak its own language.
That's a very smart approach, using the workforce who have retired to be part of this. So, Dr. Chandy, you're leading one of the biggest corporations, the medical division. So, I'm just wondering when you stepped into the corporate side of healthcare,
Mhm.
what surprised you most? Was there any difference since you come from a very hallowed
Actually,
institution?
yeah, yeah. Personal question. I took a fair bit of time to make this quantum jump.
Mm,
From nearly 4 decades of being cultured in a particular restricted frog in the well, comfortable environment to a wide open world. I began to understand, what the company needed of me, and I found that there was a lot of synergy
mm.
in what they wanted, what my present company wanted. It was not to make a profit-making vertical, but to actually bring some of the value-based healthcare from where I was into the corporate environment. So that was a challenge, but it also met with a kind of synergy that, yeah, I know this and I'll be able to do this with all the challenges ahead. So what surprised me is not the challenges. What surprised me is the high level of ethics, sincerity of purpose, and the commitment to the most disadvantaged. Unexpected from what we think is a default corporate culture. So that was actually very heartwarming that, oh, there's another side of the corporates which we haven't seen, I hadn't seen. And they were not hard nosed, they were willing to adapt. And what we are doing today in ITC healthcare is not very big. But in the areas where they have their businesses, unconnected to the business, they have reached out to the villages around. Not even a hospital based on a mobile based care, which takes care in a package across the ages, children, antenatal, pregnant women, to elderly people who have no one to support them. They've got cataract, they've got tuberculosis, they have no money to travel. It's reaching out to them. Now, to me, it's very similar to what I did for 35, 40 years. So this is something that surprised me in a pleasant way. And I enjoy what I'm doing. I came for a small time, but I've stayed on for 6 years. And so there's a lot that we can learn from the corporate environment on systems, which faith-based institutions can learn from, diligence of operations, and the concept, the belief, assumption that ethics are not there in corporate environment is not true. At least I speak for my company, that there's a high level of ethics in their business practices. So this is what surprised me. It always surprises are positive surprises, you know, which I
Wow,
could
that's
learn
very
from.
heartening to know because people have preconceived notions at times. That's
Mhm.
uh,
Yes.
so, so. Dr. Chandy, you have built systems at CMC, right? Your
Mhm.
protocols, things like that, and you are connecting them at IT. If you were given a chance to redesign healthcare in India,
Mhm.
just the basics where you think
Yeah.
we can improve a lot in India. Something missing, something you could think of.
Yeah. Yeah. So I'll have to just rewind myself a little bit. I am a thoroughbred specialist, cutting edge technology backed angioplasty, cath lab based care, which I enjoyed. The world was very restricted. It was patient coming with chest pain, very fulfilling, I must say.
Mm.
But it's only when I stepped out that I began to understand the value of holistic care. That even when I was in CMC, I understood this towards the end. When I was in the admin, I began to see that healthcare was more holistic than what I imagined. Behind every person who comes from Jharkhand,
Mm.
many people come with a gamcha full of notes for your top level care. You tell him that there is this one and there is that one and this is a state of the art care that will save your life. He believes you and he will give everything you had. But we often don't realize that at the end of a successful heart procedure or a heart surgery, you have left him with no resources because he sold his house in the village, sold his buffaloes, he has mortgaged whatever little he has, he has delayed his son's education because life was important. So, have I done justice? I have not. So my approach changed from saying very high-handedly that this is the best. I changed to say my first question would be, "आपके पास कितना पैसा है? How much can you comfortably afford for this care? You need to have heart surgery." You will say, "डॉक्टर साहब मेरे पास इतना ही है." Are you comfortable? कोई बेच के आया है? नहीं नहीं. Yeah, this much I can. If you need more, allow me to go and mortgage and no, no, no. Please don't do that. Because when I make you physically well, you must continue to be socially productive. You're the breadwinner of the family. So I've stopped believing in that. We need not know where the money comes from. We have to know. We have to know the family background and then do our best within those constraints.
Mm.
Okay? If he says, I've got only 100,000 rupees, it's possible to offer him, still possible to do 3 stents for him. So I will do that. That's the best that I can do without disrupting his ecosystem. You see?
Mm-hmm.
This is largely what is missing in the present healthcare practice. And if I were to redesign it, I would bring in a lot of holism into
Mm.
healthcare as a culture. Okay? It is not about bringing the state of the art equipment, proton therapy only for cancer. How many people are we catering to? 2% of India's population. The rest can't afford it. So, from a public health perspective, and this is the reason why healthcare is in a crisis, I believe. I just do not believe that we have transformed healthcare in any way. We are on the road to transformation, definitely with AI and all that, undoubtedly. But in India, given the tractions of our socio-economic divides, we can transform it only if we, as you said, reimagine healthcare. And that requires a collective thinking of public health specialists, government, bureaucracy, the health ministry, NGOs, the private providers, the government system to say that, hey, we are only catering to less and less with more and more.
Mm.
Can we cater to more and more with less and less? It's about optimizing what we have, not maximizing for a few. So public health has to be redefined. Public health and affordability has to be a part of the initial evaluation. Now tell me, even with proton therapy, are we curing all cancers? No. But I know personally of many people who've been totally shipwrecked and have been pushed below poverty line because of the care that was so expensive. The patient will go to the ends of the earth to raise the money. He will beg, borrow, steal because it is, well, you have said that it will save his life. It may not. It may save his life, but his family will be in jeopardy. So, if we are saying that healthcare is about service, healthcare is about a national transformation, we have to redefine and reimagine healthcare. It will not work in a totally foreign direct investment driven. 70% of healthcare is sold to foreign investor companies. They own it. It's not owned by the medical fraternity.
Right, right.
I disagree.
Probably some of the institutions are 100% uh,
Yeah,
FDIs, right?
yeah, yeah. So we must do social business, business so that this is CMC's philosophy that we defray those from the reasonable profits that are being made from private care, which has to be paid for because that's my choice. Is it easy? No, it's not. It therefore means that I, as the consultant, must be willing to take a little less as my payoff
Mm.
because I've made an oath that I have become a doctor to serve, that it has become my career, that it supports me is a byproduct of that. So we must shift and reimagine healthcare as a volume-based economy, not a high margin, few people, which is what is evolving into.
Yeah, we need to have a more human approach. I believe it's time to have a more balanced and a human approach,
Yeah.
considering the skyrocketing rocketing prices in medicine. It's very tough for people in tier 2, 3 cities.
Let me quote one example. Injection inclisiran costs 2.3 lakhs, one injection.
Right,
Semaglutide, the weight loss
right.
injection, costs 23,000 rupees and it's a course. So tell me, I can't afford it. So what are we trying to do here? And I see I'm already saying that it is being given in hospitals off-label. I recently saw a patient with an LDL level of 115, not tested with statins, but he's already been given injection in glycerin. So where is our conscience? Healthcare is a conscience-driven, service-driven domain. And we are slowly succumbing to the business ethics of it. You look at any article on the internet, where do you see articles of healthcare coming today? It's in Financial Times, Economic Times, and Money Control.
Mm-hmm.
See, the internet posts that several people write about healthcare transformation. It's all about ALOS and ARPA, what is that? EBITDA and ARPOB, and why it's growing at 25% and why we should invest in it. And, the word patient is missing entirely from those posts. That's not why I got into medicine. That's not why every doctor got into medicine. So the narrative is being changed by new stakeholders. And therefore, it's a medical fraternity that should rise up and say, no, you cannot do this. Because we are in the business of saving lives. We are not in the business of making money out of human misery. It requires honesty. It requires integrity. It requires a need-based approach. Not to find any gallbladder on a scan and say, you take it off. Now, I know that this will not be very palatable, but I'm being very honest and candid with you because you asked me the question on how to reimagine healthcare.
Thank you for being so candid, Dr. Chandy. I know it's very tough. So, you have healed, lot many people and you've trained doctors. Is there any moment, a story, a patient that you remember, end of the day, you would say it's at its heart is still a medicine, it's still a human calling? Any moment that
Yes, it
actually
is. Yeah, there are, let me tell you a story which is every time I say this, it, brings tears to my eyes. I had a patient who came with extreme heart problem. He could not move 10 feet without having chest pain. And he came with his wife. He left his children behind at home, small children. He came and we said that you need a bypass surgery because it was not amenable to doing balloon procedures. He brought his wife and he said, Doctor Saheb, and we told him that it is high risk, etc. So he made a request that please also check my wife up because if something happens to me, I want to make sure that my wife is well. There was no indication she was not complaining of anything, but we, in hindsight, we agreed to do a checkup, etc., and found that she had a block, on one of the arteries which connects the arm to the rest of the body. And that procedure, it could potentially be a problem. So he said, no, you treat her first. And we treated her. We, did the procedure, cleared the block. And when you do that, you have to give blood thinners and injections and all that. And the third day, she just had a bleed into her brain and died. So it was devastating for him to say, Doctor Saheb, kya ho gaya? And his treatment had not even started. So he didn't have his treatment and he went back. I thought I'll never see him again, but one of our afterlife care department, which is run by the priests, came forward, and that's all we could do. The human aspect in a desperate situation like that is to step out from your, avenue of what you're supposed to do and do what you can to make the rest of you stay comfortable. So they organized the aftercare, got the body cremated, and we didn't charge him anything. He went back. I never thought I'll see him again, but he came back after 2 years. He had lost a lot of weight. I was surprised that he was still with us because his disease was so bad. And he said, Doctor Arnab, I thought he will be a bitter person, but he was not. He said, I've come to thank you for what this hospital has done. And nothing I could say. But I said, what did we do? He said, the love and care I received, in the aftercare of my wife's mortal remains was very comforting. Okay. Should we have done it? It's not prescribed, it's not part of our protocol. But in our institution's culture, to reach out, to be empathetic, to be compassionate, this is the best we can do. So there's a huge human element to even a very desperate situation. That's one instance that comes to my mind.
Let's lighten it up a bit, Dr. Chandy. Yeah, I'm sure you must be having a lot of
Yeah, sure.
stories. I'll ask you a
Yeah.
couple of few rapid fire questions. See, so Dr. Chandy, if you weren't a doctor,
Okay. Okay.
would you be a chef, a painter, or
Yeah.
evangelist? What?
But nobody has asked me this question, and it's not that right from my childhood I wanted to be a doctor. Somehow, God allowed me to go into this way, and it's been a discovery as you went along. So, what would I have been if I was not a doctor? Honestly, I can't say. My father was an archaeologist, and deep down, he wanted me to take up archaeology. Just a part of his, but it never happened. Maybe I would have gone into learning history and qualifying in archaeology or something like that. I don't know. I'm just taking a wild guess here.
Your
Okay.
go-to comfort food after a long, tiring day?
See, I grew up in North India. I was in
Mm,
Varanasi, worked in Bihar and all that. So my taste buds are all very North Indian, although I'm a South Indian. So my favorite dish would be puri and chana and a fried egg for breakfast or for dinner. That's one. The other one is a South Indian dish called puttu, which is
that's it.
a column of rice which is steamed and with either chana or with plantains or with anything. I just enjoy it.
Which is your favorite city?
My favorite city, we would consider Vellore a city, which it's not. It was a one-horse town with 1 million people. I would say Vellore is because, there's a bias there. You've been there for so many years and you feel very comfortable. You want to come back from a holiday back to your home. Right now, I'm in Bangalore, and except for the traffic, I think Bangalore's a great city.
My favorite last question to the guest. If your life story had to fit in 280 characters, what would be your life story? What would you tweet?
Okay, well, very tricky question. I've never thought of tweeting my life story, but
What would be your
I would say being a physician is to actually quote, I think, John Wesley, who said
Mhm.
that do all the good you can to as many as you can, whenever you can, okay, as long as you can.
Wow,
This
that
is a
makes sense.
tweet which holds good not just for doctors, but for anyone in business, in politics, in bureaucracy, in law. That's the essence of us being human beings.
Perfect. That makes sense. Dr. Chandy, you have shown that what real leadership isn't about position, it's about presence. And thank you for being so candid. I'm really glad,
Yeah.
and we at Home Care Association will be we are forever grateful to you for being such a kind guest and being on time. Thank you, Dr. Chandy,
Let
taking.
me let me just compliment you for leading or stewarding a vertical which I think has got a lot of futuristic relevance because I don't see the cost of healthcare coming down. And therefore, the sooner and the better you develop this old system
Right.
into a modern, reformatted, appropriate care system, it will benefit many, many people, especially elderly people. You know, it's not about making that a profit vertical, but it's about really reaching out to those who are accessible in a different way. In Mumbai, an old man of 85 living in the 27th floor with small gangways and lifts, he has a heart attack. I've seen this in pictures, how difficult it is. It's to actually bring care to them. And it doesn't take rocket science.
So, any message for Home Care Association of India?
That's the message, that it's a need of the hour. It is not to rival or replace the hospital ecosystem. That is foolish. But it's to actually complement this by providing an avenue for quick discharges from the high cost system to a reasonable care system where it's more personal. Remember that in home care, there's a layer of people who are extremely important, the relatives,
Mm.
which don't have access in the hospital system. So somebody who's got limited time available, cancer patient, there's nothing more comforting than having his children, his spouse with him on those last moments. And home care allows that without compromising on what is the essential care. I can say this because, my dad, who had dementia, died at 88 in 2021. And I have been blessed with having the best hospital system to support him. But I opted to take him out of hospital because the state of the art care was making him uncomfortable. And I knew that whatever you do in the hospital, his days are limited. So I made a lamp stand into an IV stand and I put NG tubes myself,
Mm.
gave him injections, gave him the way. But he had the joy of having his wife, my mother, myself, my wife, his grandchildren with him till the last moment. Okay.
Thank you. Thank you, Dr. Chandy. Thank you.
Thank you very much.